Hey everyone, this is Dr. Medicine RX and in today's video we'll be discussing about neonatal pustular lesions. The first condition is miliaria pustulosa. It is characterized by the occurrence of papillobasicular lesions that later become pustules, and these pustules are sterile because there is no secondary infection, and these are as a result of obstruction in the intraepidermal portion of the eccrine duct. Management is to avoid excess heat and putting the infant in cotton clothes as well as in air conditioned rooms, and to use some topical soothing agents such as calamine lotion. Next condition is erythema toxicum neonatorum. So this is a transient benign idiopathic self-limiting condition that is seen in full-term infants. The onset is within a few days of birth and most commonly is seen in males. Coming to etiopathogenesis, it was considered to be a GVHD response against the maternal lymphocytes, but since maternal cells were not seen, this theory is not accepted. Now it is considered to be an innate immune response against the skin flora that gain entry to hair follicles. Coming to clinical features, so these lesions they start within 3 to 4 days of life, and at the beginning we can see a blotchy macular erythema, which is later followed by papules and pustules. So the pustules here again are sterile. So these are the two variants of lesions that are seen, and the appearance is described as flea-bitten appearance or papules surrounded by sea of erythema, because clinically there are going to be firm erythematous papules as well as papules surrounded by white or pale yellow pustules. These lesions they start characteristically on cheeks and they spread rapidly to involve the entire body, and there is no systemic involvement here. On histopathological examination, we can see hyperkeratosis as well as eosinophils in the intrafollicular region as well as perifollicular eosinophilic infiltrate. The cultures they are going to be negative because the pustules they are sterile, and the Giemsa stain it shows eosinophils. And management is that there is no requirement of any treatment because this condition it resolves spontaneously within 10 to 14 days. Coming to transient neonatal pustular melanosis. So as the name indicates, this is a transient condition which is characterized by the occurrence of pustules which heal with melanosis, that is pigmentation. So this is also a self-limiting condition that is seen at birth, and the lesions they are superficial sterile pustules and there is no inflammatory component here, and these pustules they are very fragile and they remain so for 24 to 48 hours and then they rupture and heal as a hyperpigmented macule that is surrounded by colorate of fine scales. So there is going to be generalized distribution of the lesions, and we can see both stages of lesions at a time in an infant, and the pigmentation it lasts for 3 months and there is no systemic involvement here as well. On investigations, we can see that on Giemsa stain neutrophils are present, and for management no treatment is required because this is also a self-limiting condition. Next is infantile acropustulosis. So it is also an idiopathic disorder, but it can be considered as a scabetic id reaction, or it can be because of some systemic inflammation. The onset is that it is seen from birth to 2 years of life, and it is characterized by the occurrence of crops of pruritic vesiculopustular lesions, and these pustules they are again sterile because there is no secondary infection. Sometimes they start as pinpoint erythematous papules, and the lesions they are seen over the palms, the soles and the sides of feet. On histopathological examination, we see that there is neutrophilic aggregation in the subcorneal intraepidermal regions, and on smears we can see that the neutrophils they predominate, and the cultures are again negative because there is no secondary infection for the pustules to occur. Management, so we can go for topical corticosteroids, either moderate to high potent, or we can also go for systemic antihistaminic agents because this is a pruritic condition, and in severe cases the treatment of choice is dapsone. Next condition is eosinophilic pustular folliculitis of infancy. So this is an inflammatory disorder, and it is characterized by the occurrence of recurrent pruritic sterile pustules, and these pustules they occur in crops over the scalp as well as the face, trunk and extremities. Here scalp involvement is present, and these pustules they crust within 2 to 3 days, and it can be considered as a persistent form of erythema toxicum neonatorum. On investigations, we see that there is peripheral eosinophilia, and on smears there are eosinophils present. The cultures are however negative, and on histopathological examination there is eosinophilic spongiosis as well as dermal infiltrate of eosinophils. Management, again, these lesions they disappear spontaneously, so there is a spontaneous recovery. But we can also try topical corticosteroids and tacrolimus, that is calcineurin inhibitor, as well as systemic antihistaminic agents, because this is a pruritic condition. Next condition is acne neonatorum. So acne-like lesions are seen in the infant, in the neonate. So these lesions they can present at birth or within 1 week of life, and it is most commonly seen in boys. Coming to etiopathogenesis, so there is role of hormones, both maternal and fetal hormones. So it can be because of increased production of dehydroepiandrosterone by the fetal adrenal glands, or it can be because of transplacental stimulation of the fetal's neonatal sebaceous glands by the androgens of the mother, or because of increased production of these androgens by the neonatal testicles, or it can be because of increased luteinizing hormone and testosterone levels. Coming to clinical features, so typical acne-like lesions, so mild erythematous papules and pustules can be seen, and occasionally there can be comedones as well. And the lesions they are seen over the face, that is the cheeks and the forehead, as well as the chest and the back. Coming to treatment, so this is again a self-limiting condition. Once the hormonal levels go back to normal, this condition also resolves. However, we can also try 2.5% benzoyl peroxide if required. So the last condition is neonatal cephalic pustulosis. So this condition, it is characterized by colonization of pustular lesions by Malassezia species. So for this condition to occur, there are usually certain risk factors present, such as low birth weight of the infant, or because of a prolonged ICU stay, or because of an infant that is on parenteral nutrition, or on prolonged antibiotics, or central venous catheterization or nasogastric tube. So this can occur as an inflammatory reaction to the lipophilic yeast at birth. Coming to clinical features, we see multiple papules and pustules over the scalp, the cheeks, the chin, the eyelids and the forehead. However, there are going to be no comedones. And this condition is self-limiting, but it responds to antifungal therapy since Malassezia are the cause. Thank you. Subscribe for more.